Good evening, guys, and today we are going to discuss about the pharmacokinetic principle known as the steady state. And what do we mean by the steady state? It means that the quantity of the drug that is eliminated in a unit of time is equal to the amount of the drug that reaches the systemic circulation in the unit of time. It means that the rate in is equal to the rate out. Okay, and it is achieved by the repeated administration of the drug. We administer the drug repeatedly and then we achieve a steady state. So, this was the definition. There is a concept about the plateau principle, and plateau principle means that this state in which the drug reaches the steady state is also known as the plateau principle. The time to reach the steady state only depends on the half-life of the drug, okay? It depends on the half-life of the drug. If the drug is having a half-life of 4 hours or 5 hours, or maybe some drugs have the half-life of 1 days, 2 days. It depends on the half-life of the drug, but it is independent of the dose size and frequency of administration. It means that the dosage amount, the milligrams, the size does not depend, and the frequency of administration, how many times we are administrating that drug, is also uh, not dependent on the plateau principle. This is the graph showing that there is a maintenance dose. Maintenance dose means that we are again and again repeatedly we are administrating a particular amount of drug to reach the steady state. For example, let's see this diagram. First of all, we are giving the 100 milligram of the drug, 100 microgram per liter, etc. Any units can be given here. That we are administrating IV bolus of 100 units of the drug, and we are administrating that drug in after each half-life. After each half-life, we are administrating the same amount of drug into the systemic circulation via the IV route of administration. After administrating that drug, for example, this drug has a half-life of 4 hours. Okay, after 4 hours, 100 reduced to 50. Then we again administer the same amount, we have 150 there. Then after 4 hours, the amount of the drug reduced to 75. Then we again administer the same amount, we achieve 175. Okay. Then after 4 hours, this is the third half-life and it is reduced to 88, and we administer the same amount, we achieve 188. After the fourth half-life, we reduce to 94 and then we again administered 194. After the fifth half-life, it is reduced to 97, then we again administer the drug 197, and after the fourth to fifth half-life and again sixth half-life, we are achieving 99, reduced and again administered 199, and then reduced to 100. Okay, then we again administer the drug. However, understand that after each half-life we are administering the same amount, the same units of the drug after each half-life that is passed. The goal, what is the goal? The goal here is to maintain the amount of the drug that is below the minimum toxic concentration. It does not reaches the minimum toxic concentration, and the dosage is above the minimum effective concentration. And what does this call? This is called as the therapeutic window, in which the drug is going to show us its pharmacological actions, right? We need that. It means that concentration at the steady state is maximum, CSS max, and CSS min means that concentration at the steady state that is minimum, and we are going to look at the average concentration that is in between these two, and it is in the therapeutic window. Okay, in between the peaks and troughs, we are going to have an average line. This is the dotted line, Okay, this is a dotted line in which the drug is going to work in the therapeutic window. And one more thing here worth mentioning is that the peak after the first administration of the drug is 100, right? And the peak after the steady state, what is it? It is 200, okay? And it is the twice as the peak value after the first dose. This is the double amount of the drug that we achieve at the steady state. Is the twice as amount we have administered at the first time. So this is the written same here that we have given 100 and after one half life reduced to 50 and all the way across the calculations we are having 200 approximately. Okay, we are having 200, which is double the amount of the drug that we administered first time. And goal, I have told you that we need the steady state in the plasma that is above the minimum effective concentration MEC and below the minimum toxic concentration. Even at peak levels, we don't need the drug to be toxic to our body. What is time and the steady state? What is it showing us? It is showing us that 50% of the steady state is achieved in one half life. 90% of the steady state is achieved in 3 to 4 half lives. 3.3 half lives. And 95% of the steady state is achieved in 4 to 5 half lives. It means that after 4 to 5 half lives, we are achieving the clinical steady state. Okay, we are achieving the clinical steady state, and it's very important. After 7 half-lives, and it is mathematical steady state. We do not use the mathematical steady state in the clinical scenarios because it's very impossible to achieve. 100% of the steady state is achieved after the 7 half-life, but most important thing is the clinical steady state, and clinical steady state is accepted to be reached at 4 to 5 half-lives. Okay, and it is very important. For example, if a drug has a half-life of 5 hours, okay, and we are again and again administrating that drug, okay, we are maintaining that dose. So in how much time it will gonna reach the clinical steady state? It will going to reach the clinical steady state in 4 or 5 half-lives. So it is approximately 20 to 25 hours. So it is like very important to understand the concept of the clinical steady state. What is the rate of infusion? Rate of infusion is also known as the dosing rate, okay, and it is the dose we are administrating to maintain the steady state. So let's read that. It is the desired rate at which a drug should be administered to achieve a steady state of a fixed dose. Okay, it means that the amount of the drug, the desired rate at which the drug should be administered to achieve a clinical steady state. But there is a scenario that regardless of the rate of infusion, it takes same amount of time to reach the steady state. What does it mean? It means that regardless of the rate of infusion, okay, if we are infusing 1 mg per minute, if you are administrating 2 mg per minute or 5 mg per minute, they all have the same amount of time to reach the clinical steady state. They have all same time to reach the plateau phase. Why is that so? It's a law and it's very logical that in spite regardless of the amount of the drug, they will have the same time to reach the plateau. But rate of infusion does determine the plasma concentration. If 5 mg is present, so concentration would be higher obviously in the plasma. If 1 mg is administered, concentration would be lower, but it has nothing to do with the time to reach the plateau. The time to reach the plateau for all the drugs will be the same. What is the effect of the loading dose? What is the loading dose? Loading dose means that a higher dose to reach the plasma concentration or the effective blood levels more rapidly. Okay, we were talking about the drug administration in this diagram. Okay, this diagram, that we are maintaining the dose after the each half life, right? We are maintaining the dose, and it takes approximately 4 plus 4 plus 4. It takes a lot of hours, it takes a lot of time, but in case of emergency, can we wait that long? No, we cannot. We cannot wait that long to achieve the clinical steady state. For example, if the patient is having dangerous arrhythmias or chest pain, angina, pectoris, etc. We cannot wait that long. We should administer the higher dose, okay, to reach the effective blood levels rapidly. And that higher dose is nothing but the loading dose. What is the formula for the loading dose? It is the concentration of the drug in the plasma and the volume of distribution. It's just the formula, you need to remember that. If the doses are to be administered at each half-life and the minimum effective concentration is CSS minimum, then the loading dose is twice the amount the dose used for maintenance. What was the maintenance dose in this diagram? In this diagram, the maintenance dose was 100, right? At the first time we administered 100, and after each half-life we are administrating the same amount of drug. So it's 100. So what will be the loading dose according to this paragraph? It would be twice the amount. It would be 200. So we administered 200 mg at the one time, and then followed by the maintenance dose, then we achieve MEC, minimum effective concentration. So let's talk about it. Maintenance dose. When we are administrating the maintenance dose, in the first dose, it even does not reaches to MEC level. It is below MEC. After passing one half-life, we again administer. The second is also above MEC but does not stay there any longer. After the third and the fourth dose, it starts to have the pharmacological actions that we need in the case of emergency. But loading dose is twice. It's twice the maintenance dose, and it gives the spikes in the plasma, and the level is above the MEC. The level is above the required level, right? So it's the minimum level, and the level is above the MEC. One-time bolus, it means that one-time administration of the loading dose gives spike in the plasma, and then followed by the maintenance dose. Each time we can achieve the plasma concentration above the minimum effective concentration, and that we need in the case of emergency. But if we give the loading dose only one time, it will reduce, right? After one time, after passing one half-life, it will reduce back to zero, followed by the maintenance dose. So loading dose plus maintenance dose will have the desired effect that we need, right? So it maintains the plasma levels above MEC. But we do not always use the loading doses, right? Because the loading doses are toxic to the body, and they can have dangerous effects because large amount of drug is administered um, in a short period of time inside the bloodstream, so it's dangerous. But nevertheless, in case of emergency, we can use such methods and such actions. Okay, for example, a drug digoxin, it's a half-life of 2 days. Okay, 2 days. So it reaches the clinical steady state in 8 to 10 days. We have talked that for a drug to reach the clinical steady state, it should have passed 4 to 5 half-lives. So 2 fours are 8 and 2 fives are 10. To 10 days. If the patient is having life-threatening arrhythmia, so can we wait that long? No, we cannot. So in case of these circumstances, we use the loading dose, and the levels are high, and then we followed by the maintenance dose. We can maintain the level of the drug, of that particular drug, in the plasma. So this was for today, and I hope you understand the concept for the steady state, the plateau principle, and the loading dose, maintenance doses, and etc. So I will see you in the next video. Till then, take care and